introduction short and sweet lah. Tidak perlu banyak.
Good evening. Thank you for joining our online CME Live today from Gleneagles Hospital, Kota Kinabalu. My name is Lucy, and it is with great pleasure that I welcome you to our online CME Live event, especially to those who have followed and support us from the beginning. Today we have Dr. Chan Kanwei, our resident general minimal access bariatric and metabolic surgeon, to share with us on bariatric and metabolic surgery for obese and type 2 diabetes mellitus. Before we start, let's get to know Dr. Chan a little bit more. Dr. Chan Kanwei graduated from National University of Malaysia in 2003 and was conferred the Royal Award for Outstanding Performance. He completed internship in Queen Elizabeth Hospital and Masters in General Surgery under UKM. He obtained fellowship in Bariatric and Metabolic Surgery in Taiwan, fellowship in Colorectal Surgery in Taiwan, diploma in Laparoscopic Surgery from University of Strasbourg, France. He is a certified advanced trauma life support provider and instructor. He is a life member of Endoscopic Laparoscopic Surgery of Asia, member of International Federation for the Surgery of Obesity, International Bariatric Club, Society of Endoscopic Laparoscopic Surgery of Malaysia, and Malaysia Metabolic and Bariatric Surgery Society. If you have anything to ask Dr. Chan, please send it to the comment section, or you can WhatsApp your inquiry to the phone number as stated below, and Dr. Chan will try to answer your question towards the end of our session. Without further ado, I will pass this session now to Dr. Chan. Good evening, Dr. Chan.
Hello, good evening, Lucy. Thank you for the kind introduction. Hi and good evening, everybody. I'd like to first of all thank Gleneagles and together with Malaysian Medical Association for organizing this short talk. Hopefully I can share a bit of what we do here regarding bariatric and metabolic surgery for treatment for obesity and type 2 diabetes mellitus in our center here. Okay, so I'd like to show you the first slide. This has nothing to do with the US election, but this is about the rate of obesity rise from 1990 to 2010. In the span of just 20 years in US, the obesity rate has risen by 3 times fold, and at the moment we are talking about nearly 45% of the population are overweight and obese. And this condition is not only found in the first world of like the United States, but throughout the world, and all the way to the Middle East, Asia, even Australia, and we found the prevalence is even higher among the women population. And what about Southeast Asia? Malaysia again has always secured to be number 1 in the rate of overweight and also obesity, followed by Singapore and Thailand. And we're talking about overweight of about at least 30% of the population, and obesity of at least about 15% in total, both women and men. And in this chart, in this poster that was done up by my colleague counterparts in UKM in 2016, found out there was actually 2 out of Malaysian age above 80 in the adult age who are suffering from diabetes, and 3 out of 10 of the Malaysians are actually overweight, and 8 out of 10 of these Malaysians with diabetes are either overweight or obese. So what is obesity? Is it a disease, or is it just a cosmetic outlook problem? So we know it's more than cosmetic, it's more than outlook. It causes a lot of problem, and actually is a disease by itself. Overweight causes risk factor, is a risk factor for health, and we coined the word diabesity when diabetes and obesity are found interlinked, and it is associated with an increased risk of cardiovascular disease and end-stage kidney disease, stress, depression, and even sleeping disorders. And we found that if there's benefits of losing just 5% of body weight, we can reduce the HbA1c by 0.5%, even reduce blood pressure, and reduction of triglycerides. So how do we treat obesity? So there are many modalities in the market. One of the common thing that patients actually ask for are actually drugs or medication. But out of these 5 drugs that are listed here, Ali, Xenical, Adipex, the one that commonly used and found in Malaysia is actually phentermine. So we do use that here, but we use that cautiously. And it does have some weight loss effect, but we only see about the most up to 10% of body weight loss if the patient takes the drugs over a period of a whole year. But mind you, there are side effects that we have to watch out for, including the heart rate, increased heart rate, or increased blood pressure. So what else can we do to advise our patients in regards of reducing weight? So definitely there's some association of eating healthier food, but by all means we have to know what are the good calories and the bad calories. Not all calories are bad. So when we talk about bad calories, we are referring more towards the carbohydrate calories. I think everyone should know that by now. From carbohydrate, which becomes from complex sugar to become simple sugars, and is found abundance in our food source, our daily food source every day. And even on this, so much available simple calories can be found in our these fluid diets, as you can see here. How about exercise to lose weight? So again, to be cautious, losing weight by exercise in obese patient is not normal compared to the for patients who are not overweight obese. They can't go to the routine gym, like whether it's heavy weightlifting or cardiovascular training. So not every coach are trained to treat obesity in terms of weight loss by exercising. That has to be cautious. I'm waiting for the next slide. Sorry. Okay, one of the publication that we saw in the media was Biggest Loser America, this was in 2016. So what they found, they got 17 contestants to go to 3 months of drill of a very tight regime of diet and exercise, and of course motivation, and they find them losing a lot of weight during that 3 months of so-called weight loss camp, up to nearly more than 200 pounds in one of the heaviest patient. But the interesting thing is, when they follow up this patient for the next 6 years, 13 out of 14, majority of them actually regain their weight in the 6 years after competition, and even 4 of the contestants are heavier now than before competition. This was quite interesting, because they found that diet exercise does reduce weight dramatically, but whether it's sustainable for a long term is another question altogether. Whether it's a lifestyle they can achieve, or is it something else? So what they found out was, when they have a drastic weight loss like that, metabolism of this contestant actually reduce, and they are not able to maintain such a weight loss. And only one of the contestant had a significant further weight loss, but this contestant actually went through bariatric surgery. So obesity itself is actually a very complex disorder, you might say, altogether. It may involve genetic and even metabolism with age, behavior of eating. It could be psychologically induced, and the environment that we are, whether it's our friends or family, or the culture that we have, who reward ourselves with eating, and also the socio-economic status, what type of food that we spend on. So obesity is a complex, multifactorial and chronic metabolic disease of excessive body fat deposition, and it's mainly of overweight of body fat. So what we know is the body seeks a stable adipose tissue mass, just like our liver mass or our red blood cell mass. So there is a hemostasis of our body fat in our body, and if we try to increase it dramatically, the body will actually reduce us from overindulging in food. And if we try to increase exercise, then or burning off the fats, and then the body itself will tell us to regain back that body fat mass. And these are all actually controlled in the brain, and there's actually a weight metabolic set point. So each time we try to diet or exercise to reduce weight, there will be hormone adjustments to promote weight retention and therefore increase appetite and slowing down metabolism. So it's not so simple as going for exercise or reduce your diet or restriction of calorie. There will be hormones involved, and one of the stronger hormones that we see is actually the hunger hormone ghrelin, which is found in especially the fundus of the stomach. And this will give a feedback to the hypothalamus, and if the patient, if a person is already full, then we have a satiety hormone like PYY, GLP-1 or CCK, which actually tells us to stop from overeating. So this body fat mass set point is actually altered over years of exposure by abnormal dietary constituent, unhealthy muscles, sleep deprivation or stress, disrupted circadian rhythm, and weight gain inducing medication like insulin. And we do have a lot of modality to reduce weight, from healthy diet, regular physical activity, more and better sleep, stress reduction, stable eating patterns, and weight stabilizing alternative. But the modalities are not so severe compared to maybe some drugs, especially phentermines. It has higher effect to reduce the body fat set point. But out of all these, we found out bariatric surgery is one of the most powerful tools to reduce and control a sustained weight loss. So in this vicious cycle, we found out that bariatric and metabolic surgery is able to reduce the hormone levels and adjust to support weight loss and to sustain that weight loss. So one of the famous surgery that you should heard of is gastric bypass, Roux-en-Y gastric bypass, which is in the world about 60 to 70 years now, and it was an incidental finding by a surgeon named Mason when he did some sort of gastric bypass for benign gastric pathology. And what they observed was there was weight loss and sustained weight loss in this patient. And from those days, it was modified to this Roux-en-Y gastric bypass, as you see today in this illustration. But over the years, especially for the past 20 years, there were many modifications of such surgery. And all these surgeries are involving the stomach and most of the time involving the small intestines. So gastric bypass is only one of them, and later on that we found out there was a new technique of even putting a band, if you heard of a gastric band, or even plication, and even come up with sleeve gastrectomy, like in this picture here. And there's also modification of gastric bypass. And what you see here is a stomach modified to be a small pouch and creation of one gastric anastomosis. This is quite a popular surgery now, especially in certain part of the world like South America and also in the Europe and also India. And for the past 15 years, there came about of sleeve gastrectomy, whereby looks much simpler than gastric bypass. It's a reduction of the stomach capacity by removing about 70 to 80% of the stomach portion. And this is an irreversible procedure by creating a banana-shaped like stomach. And there's also sleeve gastrectomy with some kind of bypass of small bowel to enhance the further action of sleeve gastrectomy. Some may heard about gastric plication or gastric band, but this involves a reduction of the volume or the intake of a patient, but without much of the hormonal changes. So how we know it is proven that bariatric surgery is most effective compared to lifestyle and medication changes? Gastric banding, gastric bypass produce a very significant weight loss, up to 40% of the total weight loss, especially for the first 2 years, and sustain over the 10 years as seen in the Swedish obesity trial. And how does it work? Not only does gastric bypass or sleeve gastrectomy reduce the volume of intake and also reduce the absorption, which was the previous understanding, but we found out that there's more to it than just mechanical changes. There are also hormonal changes when it comes to bariatric surgery, especially the reduction of ghrelin hormone, from the fundus of the stomach, and the increase of the incretin hormone from the small bowel like GLP-1 and PLY, which has further reduction of weight and also some good effects towards diabetes. So the mechanism of weight loss is complex. A lot of postulation has been done to find out why, from decreased appetite drive to altered food preference. They can have change of smell and taste, increased brown beige thermogenesis, increased circulating bile acids, altering luminal bile acid pool, altered microbiota, altered circadian rhythm regulation, which is weight independent of improvement of diabetes, intestinal epithelial hypertrophy, altered fat mass set point, and vastly altered global metabolic physiology. So all of these effects will change not only the physics, the hormonal, but also the physiology of obese patients. And the most dramatic change that we see is actually the resolution of diabetes mellitus, type 2 diabetes mellitus. Resolution, but not reversal. And we see more than 80% of our patients who are diabetics have resolution of diabetes. And also reduce of obstructive sleep apnea, which is very high incidence in diabetic patients. So one of the landmark trial was the Stampede trial, which was run in Cleveland Clinic, and it was run over a period of 5 years. So what they did was they took 150 uncontrolled type 2 diabetes mellitus and randomized them to either full medical therapy, gastric bypass, or sleeve gastrectomy in equal group. And their primary endpoint was to achieve a HbA1c target of less than 6.0%. So in the first year, they found out that they achieved only 12% of this in the best medical therapy, and up to 42% in the gastric bypass group, and 37% of the sleeve gastrectomy group. And this shows a significant more diabetic patients achieve glycemic control following bariatric surgery. And not only that, after 5 years, what they saw was a sustained reduction of the HbA1c of at least -2%. And Roux-en-Y gastric bypass were able to achieve 29%, and sleeve gastrectomy were able to achieve 23%, as compared to medication alone of only 5%. Furthermore, they found out that heart medication, insulin, and other drugs for diabetes are much lower after surgery. And after that, 88% acceptable glycemic control even without insulin in the gastric bypass or the sleeve gastrectomy group. And you can see in this chart here, especially in the gastric bypass, at least 45% after 5 years is actually off any kind of medication for diabetes mellitus, whether it's monotherapy, dual therapy, or more, or even insulin. And actually only about 90% of only less than 10% of the gastric bypass group will still need insulin, including the sleeve gastrectomy group. So what we know here, metabolic surgery for type 2 diabetes diabetes mellitus works not only because of weight loss, because it's quite independent of weight loss. Weight loss does happen in the most significant in the first 3 months and 6 months, but the drop of the HbA1c is seen even right after surgery, even the first 1 month. So it can be contributed by, of course, the immediate calorie restriction, and other than that is the hormonal changes that the patient goes through. And we found that it is independent of the weight loss. So because of all these findings that we've seen in bariatric patients who are diabetic, so the International Diabetes Federation published this in 2016 for the acceptance of bariatric surgery to be part of the treatment that should be offered to type 2 diabetes mellitus patients who are obese. So they even class them to non-obese, class 1, class 2, class 3. From class 1, it can be considered as an option for patient, and from class 2 onwards, in class 3, it should be recommended for patients who are diabetics and obese. And the class of 1 obesity in the Caucasian group or the Western world are from BMI 30 and above, but for Asian is from BMI 27.5 and above. This is because we recognize that for Asians, there are higher risks of diabetes and cardiovascular incidence for a lower BMI. So we take 27.5 as our cutoff for treatment for diabetes mellitus via bariatric surgery. or other words, metabolic surgery. So in this study, we also found that there's also low incidence of type 2 diabetes mellitus in patients who undergo surgery before they develop diabetes mellitus. So in obese patients of BMI more than 30, when they follow them up for the next 15 years, almost 40% will develop diabetes mellitus. But patients who have not developed diabetes and they have gone through bariatric surgery, they also have lower down incidence of diabetes mellitus, as seen here in the graph. And apart from that, in the Swedish trial, it was follow-up patient for more than 10 years, and it's a prospective study. They show that metabolic surgery or bariatric surgery does reduce the mortality rate, overall mortality rate of obese patients by at least 10%. How about the safety of bariatric surgery? As compared to other surgery like colectomy or hysterectomy or cholecystectomy, even though obese patients are already at a high risk of with all these metabolic disorder, and it seems like such a complex surgery, the safety profile of bariatric surgery is quite good compared to the others. Gastric bypass overall has about 0.4% complication and mortality of 0.2%, which is 4 times lower than even a gallbladder surgery. So how do we prepare patients for bariatric surgery? Well, to include them to be indicated, we only take the adult age of 18 to 65 years old. Well, this is just a guideline. Sometimes the youngest patients we have here is actually 17 years old, and the BMI that we use is 35 and above without diabetes mellitus. And of course, if they fail non-surgical intervention, we give them about 3 to 6 months to try to modify their lifestyle, and which is a good indicator of how they would succeed later after surgery. And contraindication are patients who already have cancer, still on treatment, or patients who have organ failure like kidney disease, or of course heart and lung disease, major psychiatric disorder like schizophrenia or major depression. We have to be cautious, and also patients who have previous laparotomy done. And patients are actually seen by a whole team. It's not only by the surgeon. We have a bariatric dietitian here. We have the physiotherapy or the fitness coach. The will assess them for fitness of anesthesia. We will do a routine upper endoscopy to check the condition of the stomach for ulcers or H. pylori infection. And we have physician involved, bariatric physician, to control their comorbidities like hypertension and also their sugar profile. So here in Gleneagles, we have a full team, especially the physician involved to prepare the patient pre, during, and also post-op, and dietitian who will actually guide the patients to a modified diet, especially after the bariatric surgery. So we also have a scoring system. There's actually many scoring systems at the moment. Some are complex, some are simple, and involves actually the duration of their diabetes, the medications that they use, the number of medication, whether they are already on insulin therapy, and how good their glycemic control. And we also can measure them by a fasting C-peptide to see their function of the pancreas, to decide whether they are actually mild, moderate, or even severe diabetes mellitus. Some papers have shown that for mild and moderate diabetes, they would suggest gastric bypass, and for the severe diabetes, even though they should go for gastric bypass, but they suggested sleeve gastrectomy based on this American paper. But these are just guidelines. Guidelines because there are many types of bariatric surgery at the moment, from gastric bypass to a one endoscopic gastric bypass to a sleeve gastrectomy, or even a sleeve gastrectomy plus a bypass. So how do we choose? There are many parameters to choose from. So, but anyhow, these surgeries are done just like appendicectomy is done via laparoscopic these days. And being obese patient, we do not want to intrude via a big scar or laparotomy. It will cause more post-op morbidity. And all these procedures, even though how complex the bypass seems to be, it is done by a keyhole surgery or laparoscopy. So example, this is gastric bypass. We actually have to make a gastric pouch. about the size of 20 milliliter only, and a bypass of bowels up to 300 centimeter combined. So this is an example of a video of a bypass done here. So here is a loop of small bowel. We are already connected to the gastric pouch, and we use devices such as a stapler device to actually transect and divide bowels. Example is this. And from there, laparoscopically, we will do the reconnection both by stapler and laparoscopic suturing. The next one, most commonly done surgery now, is sleeve gastrectomy. Most of the centers in the world will actually do about 70 to 80% of their patients who undergo sleeve gastrectomy compared to a gastric bypass these days. And these are usually achievable because of stapling technology. Example again, like this. It's a large stomach, and with a calibration with a calibration tube inside the stomach, we can precisely create sleeve-like, banana-shaped like sleeve gastrectomy. And you can see these surgeries are quite smooth and bloodless if done in the proper manner. Okay, and as I said earlier, for exercise for obese patient has to be tailored and specific for what they can do. Not everyone can be doing the same exercise that we see in the gym. So here we have the physiotherapy or the rehab team together with a fitness coach, and to tailor them to specific exercise that they can do, not jumping jacks, not climbing stairs because of their sheer weight. So what have we achieved here so far in KK? Total we have more than 130 cases done here. And we can see majority of the procedures involve a sleeve gastrectomy, and only up to about 25% are sleeve bypass procedure. Female patients are more than male, 3 to 1, and the weight range that we see here are from 70 kilos to even up to 205 kilo of BMI of 70. And it's quite encouraging to see resolution of diabetes. Up to 95% of our patients, 1/3 of patients have diabetes, and we see 95% of remission and off medications. If they do not off medication totally, at least they'll be on one, but without insulin. And about 42% of patients are hypertension with 80% remission and off medication. And almost 100% of our patients actually have remission of obstructive sleep apnea. And how about complications? We do see some complication, but it's not common. We have done one revision so far for shortening of a bypass because the patient was losing too much weight and protein. We have a minor sleeve leak. We was dealt with drainage and also stents. Patient fully recovered. We have a small bowel perforation, which was we have to go in a second day to repair it, and so interherniation after a roux and white gastric bypass. So far, we have no mortality or severe morbidity. So this is one of the example of my earlier patient 5 years ago. He was 125 kilo, and we did one anastomosis gastric bypass. This picture is to show you that an operation was done 1 day after operation, and she's able to sit up, and in fact, most of our patients actually discharged the next day. This is achievable because of laparoscopic surgery or keyhole surgery. This is one of our earlier patients who was a BMI 50, a weight of 144, who has no diabetes but has poor quality of life because of obstructive sleep apnea and social stigma. So he had a sleeve gastric and a bypass surgery done, a sleeve gastric with a small bowel bypass. And after 12 months, he was able to achieve 70% of excess body weight loss, resolve OSA, and of course, he can show you the same pants he was wearing before operation. This is one of our patients who was not heavy, middle-aged lady, but her blood sugar was quite high, HbA1c of 12.2. Her BMI at that time was only 36. So we did a metabolic surgery of a sleeve gastrectomy with a proximal jejunal bypass. And after 1 year, she only reduced 10 kilogram of weight. But the significant was, from a HbA1c of 12.2, it was reduced to 5 and above without any medication and still sustained so. And it's been about, I think about 3 years now, 3 years plus now. So one of our heavier patient of BMI 64 who have OSA and hypertension, and after 12 months he was able to reduce his weight below 100 kilos. And one of our heaviest weight patient is BMI of 72.6, and we definitely have to resort to gastric bypass, not sleeve alone. And he's able to reduce his weight to less than, I think should be about 105 now after 12 months. So in summary, obesity is a disease which leads to multiple metabolic disorder, comorbidities, and shortened life expectancy. And bariatric and metabolic surgery is a treatment of obesity and type 2 diabetes mellitus. It is significant and by significantly reducing weight and sustaining it, and also shows resolution and remission of comorbidities, especially diabetes mellitus. And bariatric surgery is only part and parcel of bariatric care by a multidisciplinary bariatric team. So a good team and center is the key to success. Thank you.
Thank you so much, Dr. Chan. We have received a few questions from the viewers. One is from Dr. Nagaratnam. Can bariatric surgery cause long-term metabolic disturbance besides anemia?
Yep. So thank you for the question, Dr. Naga. We do see some patients who have anemia, especially if they have already, especially if they go through gastric bypass. So and especially if they are female in the fertile age with regular menses, for example. So we are quite selective in that to choose which bariatric surgery which is more suited for them. So the higher incidence of anemia is seen in gastric bypass, but we see less in sleeve gastrectomy. So we try to avoid gastric bypass due to this reason. Apart from anemia, we do see some calcium deficiency, but not in our set of population. And whether it's vitamins or other metabolic, we do not see that because we do follow them up for at least 2 years, and we do encourage them to take multivitamins on a daily basis. Yep.
Okay, another one which is from Dr. Leong Hin Kao. People love to eat. Any psychological effect on loss of satisfaction from low quantity of food consumed after surgery? Do they need special diet after surgery, or bloating or indigestion sensation post-surgery?
Yes, very good question, Dr. Leong. So definitely dietary have to be changed. Diet habit have to be changed after surgery by the sheer reduction of the volume of the stomach. So in fact, the first 2 weeks after surgery, patient will have to go to a fluid diet, complete fluid diet for first 2 weeks, followed by 2 weeks of soft diet, then so-called normal consistency diet, where the dietitian will be guiding them. So these are quite drastic changes that patient should know and will know before embarking into the surgery. So they have a pre-op counseling done by our team, including the dietitian, to show them what they have to go through step by step. And most of our patients actually have patient support group. We actually enroll them to a patient support group. They can share from other previous patients, and a lot of them do check online or even YouTube. And the other thing is, yes, we do advise them on certain habits that need to be changed, especially for the first 3 months. We try to guide the patient not to have their regular meals with their friends or family, to have a separate time, or if they truly have some kind of psychological stress that they need to eat something, we do provide them with psychological support.
Okay, next one is from Dr. Ganesh Shananda. How much does sleeve gastrectomy cost?
Oh, should I answer that?
Yeah.
All right, thank you, Dr. Ganesh, for that question. Roughly in Malaysia, sleeve gastrectomy will cost about 30,000 ringgit, around that vicinity, anywhere in Malaysia. That's our usual price.
All right. That
And
was
that charge includes of the whole admission to discharge and the surgery, which takes about 2 to 3 days of stay in the hospital.
All right.
Yeah.
Okay. So that was the last question from the viewers. Dr. Chan, do you have anything else to share with our viewers today?
Some may ask about the safety of this surgery in this time of COVID crisis. So far in our setting and in Malaysia, we are quite strict with admitting patients. We screen them, and so far it is safe to go through this surgery. And some has also raised that the concern about that the risk factor of severe COVID crisis was seen in patients who are obese. So some would recommend that by reducing weight, whether by means of non-surgery or surgical method, would benefit from to protection against COVID. Is a good question, but it has to be seen. But we are not stopping the service. Yeah.
All right. Thank you so much, Dr. Chan, for the updates. To all our viewers, please don't forget to scan the QR code at the end of this live by using your MMA Doctor Phone application to get your CPD point now. If you have any difficulties to scan the code, please click on the link in the comment section to confirm your attendance manually before 8 p.m. today. We have another online CME session with our resident orthopedic arthroscopic sports and joint reconstructive surgeon, Dr. Dharmalingam Mutia, on the topic of hip replacement on 27th of November at 6 p.m. Let me know if you are interested. We will share the details with you. We have come to the end of our online CME today. Thank you very much for watching and see you next time.